I'm Rohit from the National Heart Institute. So I'm going to talk a little bit about wide complex tachycardia. To make it easy, I guess that's a little bit of a misnomer because WCT is actually very difficult, and a lot of times you can be confused. The basic question is going to be VT or SVT. So let's just get to some basic definitions. What is a wide complex tachycardia? So a QRS with a width of more than 120 milliseconds has three big boxes with a heart rate of greater than 100 beats per minute. So you can either be sustained or non-sustained. And non-sustained would be something that is 3 beats up to 30 seconds. Anything apart from this would be something that is sustained. So a very basic generalized definition, very easy to remember. So you just need to see your QRS duration, you need to see the heart rate, and to know whether it's sustained or non-sustained. So just before we get along, maybe some misconceptions. People always assume that if you have VT, you're going to be unstable. So they may underdiagnose or overdiagnose the situation. A patient who's got SVT is always going to be stable. Drugs are always safer than cardioversion. So these are some common misconceptions. Certain drugs given in the wrong situation may propagate the tachycardia to becoming something that is fairly stable to something that's unstable. So you need to know what you're dealing with. So differentiating a wide complex tachycardia into a supraventricular tachycardia or ventricular tachycardia is very important. So what is the most important thing you need to know is mechanisms of ventricular tachycardia. The common mechanism, the most common would be re-entry. So you need two distinct pathways, basically one of conduction and one is slow conduction, and then you get a re-entry. This is commonly seen in abnormal myocardial scarring in patients who've had myocardial infarction, whether it be fibrosis from any other causes such as cardiomyopathy, it could be having myocarditis. Triggered activity occurs due to early or late after depolarization. This is commonly seen in TDP, Torsade, and abnormal automaticity. This is accelerated abnormal impulse generation in certain regions of the ventricular cells. Now, this is commonly seen in electrolyte imbalances and things like that. So the first step, what do you do when you see a patient with wide complex tachycardia? So obviously, it's going to be either someone with pulse or pulseless. So you have to always look at the patient and decide what is the next step, whether the patient is stable or unstable. And never forget to follow your AHA, ACLS guidelines for management of wide complex tachycardia. And always sedate before cardioversion if you should decide to cardiovert a patient. So when you come down to wide complex tachycardia, there's basically a few differential diagnoses that you need to consider. The most common being ventricular tachycardia up to 80%, SVT with aberrancies 15%, pre-excited syndromes meaning WPW with atrial flutter, atrial fibrillation, atrial tachycardia, or antidromic reentrant tachycardias, pacemaker-mediated tachycardia, which can look like a wide complex tachycardia, electrolyte disturbances such as hypokalemia, and use of antiarrhythmic drugs, which can induce a widening of the QRS, generally seen in class 1C or class 3 agents. So this is the general differential diagnosis. When you're looking at a wide complex tachycardia, number one, look at the patient. Get the history, look at the ECG, and then make a diagnosis. So what can help? What can actually help us make the diagnosis? We know that in patients more than 35 years old, 85% you have a positive predictive value that it is going to be VT, just by the age alone. Underlying heart disease, if they have ischemic heart disease, previous MI, low ejection fraction, that is a predictive value of about 90% that what you're looking at is actually a ventricular tachycardia. History of device therapy, that's going to rule in or rule out things. If the patient has an ICD and you see a wide complex tachycardia, you've got clinical history, you may be dealing with a VT. Whereas if the patient has a pacemaker and the diagnosis is not ischemic heart disease, and you see a wide complex tachycardia, then you may be dealing with something called pacemaker-mediated tachycardia. So termination on drugs, so beta blocker, CCB, adenosine may lead towards this being an SVT. Lidocaine mainly in VT. Amiodarone and procainamide can terminate both SVTs and VT. So not really useful. But the thing that is least useful will probably be symptoms, because generally they're going to present with palpitations, giddiness, may or may not have chest pain. So symptoms would not be the thing that's going to help us the most. So ECG, what can the ECG do to help us differentiate VT? Now, if you look at the slide, there are so many things here. That's right, there is AV dissociation is always VT. You can look at the Brugada algorithm, which I will go through later. You have the AVR algorithm, where you look at if AVR is predominantly positive, you're going to have a situation where it's most likely VT. You can also look at the initiation and the termination and the voltage change, and this also would lead towards VT. You have Josephson's sign over here, which is a notch on the downstroke on a negative QRS complex. And you're looking at Brugada's sign, which is looking at the change in the RS interval from the start till the peak of the S, which is going to be more than 100 milliseconds, leads towards a ventricular tachycardia. If you have a very wide QRS complex, that leans towards more being a ventricular tachycardia. Not all the time, but that is, if it's more than 160 milliseconds, it's quite predictive. If you have extreme axis, it's ventricular tachycardia. If you have right bundle branch block with left axis deviation, or you have left bundle branch block with right axis deviation, all these things lead towards it being more towards VT. Now, these are algorithms that are used to help us distinguish the difference between a VT and an SVT, but it's not set in stone. A lot of these algorithms can be fooled by the ECG and also by the person interpreting it. So, what do we need? This is just a summary of those things that I mentioned just now. Other things that can help diagnose or distinguish VT: negative or positive concordance, Brugada's sign and Josephson's sign. Josephson's sign, you can see there's a notch over here at the downstroke. And Brugada's sign is the R to the S should be greater than 100 milliseconds, which is right over here. That's right there. If you see fusion beats and capture beats, then this is ventricular tachycardia. So a fusion beat is basically a combination of your VT with your sinus beat. When the ventricle is actually depolarized and captured, you get a capture beat. When you have a fusion, that means your VT with your capture beat, which is a normal sinus, you get a combination, which is an abnormally looking, what's called ECG here, which looks like it's called a fusion beat. So these are things that are going to help you make a decision. If you have AV dissociation, meaning that you have more V's than A's, then you have ventricular tachycardia. So it comes down to which algorithm should you choose. Now, number one, it needs to be identified quickly and correctly because, of course, this is time sensitive. Multiple proposed algorithms over the past 3 decades. Most commonly used are the Brugada, which was in 1991, and Verica in 2006. Now, these algorithms showed a high level of sensitivity and specificity. But the issue is that I'm sure most of you are like me, you probably can't recall. It's hard to remember all the requirements to make a diagnosis of ventricular tachycardia. So you pick the ones that you remember and you know it well, and you use them to make a quick decision. Remember, clinical history is very important. These are not exams where they give you an ECG and you make a decision, but these are patients who are in front of you. Okay, so what makes an ideal algorithm? Something that's easy to use, something that's quick to use and remember, and one that can accurately and quickly identify ventricular tachycardia. So that's what makes a good algorithm to decide. So just a little bit more in detail, we talk about the Brugada criteria. So there are 4 criteria. So each one of them has its own sensitivity and specificity. So you have an absent RS complex, basically a positive or negative concordance in chest leads. If any of the RX complexes in V1 to V6 have an RS of greater than 100, which is also basically your Brugada sign over here. Any evidence of AV dissociation, any evidence of fusion or capture beats. And if all these fail, then you look at any signs and check for characteristic features in V1, V2, and V6. Now these are looking at the morphology basically. You look at the patterns of the R wave, you look at the pattern of the right bundle or the left bundle, and you decide whether this is a ventricular tachycardia. As you can see, it's long and it's not easy to remember. And we go to the Verica algorithm, which looks at your AVR. So if your initial R wave in AVR, it is VT. Sorry. So if there is no initial R wave in AVR, then you look at the width of the initial R or Q wave. Is it more than 40 milliseconds? Now the reason this is important is if it is a ventricular tachycardia VT, it's being depolarized from the ventricles outwards. So it's not going down the His-Purkinje system, the normal conduction system. So you tend to have more of a slurring. So it takes more time from the baseline or the isoelectric line to go up into the R wave or the Q wave. So that's why you have a prolongation, and generally more than 1 box. So that makes it a VT. If there's notching on the initial downstroke or the predominantly negative QRS, this is Josephson's sign. If you have these things in VT, VI over VT less than 1, that is the voltage change in the initial 40 milliseconds over the voltage change over the terminal 40 milliseconds, that ratio being less than 1, then that is VT. Once again, this is the change because the depolarization of how the impulse is generated in VT from the myocardium over out into the rest of the heart. So this is a new algorithm, and I think that this is going to be very helpful for people sitting in emergency, people sitting in the Department of Medicine who do not have the backup of maybe an electrophysiology team. Now, the basal algorithm, which was recently published in the JAC in July this year, if I'm not mistaken, 2022, it takes into account structural heart disease. So if you have a patient who has a history of myocardial infarction, who has an ejection fraction less than 35, who has an ICD, who has a CRTD, if you have this, plus you have lead 2 showing time to peak, so you only look at lead 2 and you only look at lead AVR. So if you have these two things and your time to peak, the first peak in lead 2 is more than 40 milliseconds. As you can see here, it's slurred up, that's more than 40 milliseconds. Or if lead AVR has a similar finding from the time to the first peak of more than 40 milliseconds, if you have 2 criteria and above, meaning to say this is positive, and you have history, this is VT. If you have only 1 or less, then it's most likely SVT. So this basal algorithm makes it very, very simple. If you look at the ECG, all you need to do is you need to look at lead 2, you need to have AVR, and you have the patient's history already with you because you are seeing a patient, not an ECG. So this actually was derived from EP studies from 2010 to 2014, analyzed the ECGs and blinded to EP diagnosis. So basically, they used it to check the basal algorithm, the Brugada, and the Verica, and it was verified with electrophysiologists. And what they came up with was that it is as good as the Brugada and Verica, which is the 2 most commonly used algorithms for distinguishing VT, but a whole lot simpler. It takes into account a lot of things that you already knew and simplifies it into looking at lead 2 and lead AVR. So when you have these 2, you can make a very, very quick distinction. We will go through some ECG shortly, and then we will see and test whether this actually works. But like everything else, there are limitations. So if you look at this first ECG, okay, this is a VT, all right? You have to take my word for it, but we'll look at other ECGs. But this is a VT, okay, arising from the left ventricular outflow tract, correctly identified, okay? However, in fascicular VT, ILVT, what happens is you can have 3 types. There are 3 types. There's posterior fascicular VT, there's anterior fascicular VT, and there's upper septal fascicular VT. Now the issue is that the conduction is going down the his system, and there is a re-entry circuit at the level of the fascicles. So you tend to have a narrower QRS. So you tend to have a narrow QRS, you tend to have a right bundle branch morphology, and it tends to be misdiagnosed as SVT as opposed to VT. You can see in slide C here, this is a typical atrial flutter with 1-to-1 conduction, and it's correctly classified as SVT. Whereas here you have an SVT with aberrancy which fails. So there are limitations to the basal algorithm. So when one fails, you have to look hard. Maybe use the other parameters. Look for Josephson sign. Look for Brugada sign. Look for AV dissociation, which tells you that it's always going to be ventricular tachycardia. So let's maybe start with some ECGs. So this is the first ECG. Everybody can have a look at it. I'll just go to the question quickly. So this is a 34-year-old female with no known medical illness, presented with palpitations for 1 day. Now we just go back to the ECG, and I'll give you a couple of minutes to look at it, and maybe we can get a poll up. Okay, great. So, looks like everyone, maybe we can go back to the ECG. So, it looks like everyone said SVT. Very good. So, let's dissect this using the Brugada criteria. All right. So, is there any, uh, is an RS complex, absence of an RS complex? Yes. Is there any positive or negative concordance? No, you can see that this is negative and this is positive, so that's out of the way. Is there RS more than 100 milliseconds in V1 to V6? As you can see, no. It's very, very narrow. Is there any capture beat or fusion beats? You can see very clearly here. You can hardly see the P waves, but there may be a P wave buried right up here. But there does not seem to be any AV dissociation. And criteria 4 is not met. So Brugada criteria says this is SVT. Similarly, with the Verikai criteria, you can see, is there an initial R wave in AVR? No. So we move down. Width of the initial R or Q wave more than 40, you can see no. It's very, very sharp. Notching, Josephson sign is not there. And VI over VT is not. So this is an SVT. So very quickly, when we use the basal criteria, all we had to do was look at lead to and AVR. And if you count from the start to the peak is less than 40 milliseconds. And when you take the AVR from the start to the peak is less than 80 milliseconds with no history suggested. So this is SVT. So you one look, you know this is SVT. So let's look at this ECG. I'm just going to skip over the question. I think the question gives you a lot of idea probably what this is. But this is a 57-year-old man, background of diabetes, hypertension, primary PCI 3 months ago to the LED. Go back to the ECG. Maybe get a poll. Perfect. We'll just move right on. Can we get to the back to the this is the next question. Can you go back? Yeah, okay, great. So a bit difficult to speak to the audience here, but looking at this ECG, all right, let's maybe not even let's try and look at it very quickly. Let's look at lead 2 and AVR. Just from these two leads, you can already make a diagnosis. You do have some AV dissociation. If you look very closely, you can see the P waves. There's a P wave here, not so much there. So there is some AV dissociation. So AV dissociation is always ventricular tachycardia. There is obviously the basal criteria is met with the history. So 3 criteria out of the 3 are met. And if you look at using a Brugada sign, you have concordance, you have AV dissociation. I do not see any capture beat or fusion beat here, so that is not met, but you have a diagnosis of VT being met. Similarly, with the Verikai criteria, you got this is not met, so width of the initial R wave more than 40. So if you look for the initial R wave, you can see it's a long slurring peak. So this is ventricular tachycardia. And of course, we went over the basal criteria at the start, and this definitely proves that this is VT. Now this is the third ECG. So maybe look at the ECG, and we won't comment on we won't give you the history yet. Why don't let's see based on the ECG alone, using the Brugada, the Verikai, or the basal. I would use the basal here. Whether you can come up with a diagnosis. So maybe let's run the question, the poll right now. Okay, great. So I think 70% said, 74% said VT. So let's look at this without going through the slide deck where I actually explain it. Let's look at this. Let's see what we're looking at, okay? We have a right bundle branch block morphology. We have a fairly wide QRS complex. I'm sure we all agree on that. We don't have positive concordance, so Brugada is not fit into the first plan here. But if you look very closely, what is that? That's A, it's a P wave. It's not everywhere. Even here, if you look, there is clear signs of AV dissociation. So we can meet Brugada's criteria here. There is AV dissociation. And if you look over here, how broad is the QRS? From the start right up to the peak, and even in AVR. So basal criteria also met. So this is met. You can see this. This is the AV dissociation we were talking about. So look very carefully for AV dissociation. That's because the ventricle is firing at a faster rate than the atrium. So off you get the signals that's coming in. The wavefront from the atrium is seen. So this is AV dissociation. Vertical criteria met. Simply put, you can see there's an initial R wave that is already met. Width of the initial R01 is more than 40, that's also met. So this is obviously ventricular tachycardia. I don't really see an obvious Josephson sign. I do not see one, so that is not met. But most of them are met, so this is VT. And the basal criteria also does the same. All right, let's see ECG number 4. Can we get the question up, please? And the poll. Okay, so 50-50, close to 50-50 split down the middle, yeah? I think some said neither. It has to be either VT or SVT. It's not going to be neither. That's just a red herring out there. So let's go over this again, okay? So we have some form of right bundle here. It doesn't have concordance negative nor positive. All right, great. That doesn't matter. Do we have AV dissociation? Let's look together. So that's a P wave that's coming up here. So a retrograde P wave that's coming up after the ventricle is being activated. You can see one there, marching along. And it's at the same point at all times. Okay? Do we see a notch? No, we don't really see a notch. Let's look at the peak. Let's look at lead 2 and let's look at lead AVR. That is the peak of the R wave. That's the peak of the R wave, peak of the Q wave. Any evidence that is more than 40 milliseconds? No, it does not. So that is a SVT. Okay? So ECG number 5. Have a look at this ECG. Okay? It is broad. Let's have the polar. Okay. So I think, what was the poll again? So about 55% said VT, 5% said SVT, and neither was about 40%. So the answer actually is neither VT or SVT. Now the clue is in the question. If you look at the question here, let's look at the question. It's a 78-year-old lady. Yes, she has ischemic heart disease. Fine. But she has a pacemaker for 6 sinus syndrome. Okay, so we go back to the ECG. Somewhat of a trick question. If you look carefully, you can see pacemaker spikes. These are all pacemaker spikes. So this is pacemaker-mediated tachycardia. There are many mechanisms of pacemaker-mediated tachycardia. There are a few things that can be happening here. The other thing that can be happening is patient has 6 sinus syndrome. So she may be having tachybrady. So it may be tracking the rate. But why is tracking the rate not very common? Because this is 1, 2, 3, 4. This is about 150 milliseconds. This is too fast for it to track. So most likely this is TMT. But of course you need to do the interrogation of the device to know exactly what is happening and what triggered this to begin with. But this is not ventricular tachycardia, nor is it SVT. So look carefully at the ECG. You see a pacemaker spike and you see a very broad QRS complex. Okay? It's all your left bundle morphology because you're pacing in the right ventricle. Number 6. Let's have a poll. I think by now, probably everybody would get this right. Yeah, 75%. Great. Let's have a look at the ECG. So let's use what is the most simplest criteria that we've met and figured out today, basal criteria. Let's go. If it does not fit the basal criteria, then we try and use the other criteria because they have more information. So just by virtue of basal algorithm, she does not fit the history, so that's 0 over there. We look at AVR, does not fit the criteria for being more than 40 milliseconds because it's very fast activation. Similarly in lead field. So this is SVT. And ECG number 7. So let's have a poll on this ECG. Okay, good. So the last ECG got 92%, so that's good. Let's go back to the ECG. History favors your VT diagnosis there, obviously. You can see the P waves in different areas that is there. This may be Joseph's sign over here. You can see a notching, the downstroke even here. Your AVR is broad. From the initial point is 40 milliseconds and greater. Similarly with lead 2. So on all fronts, this is ventricular tachycardia. So rightly diagnosed by 90% above you guys. So very good. So the reason I was going to put this slide up is because you need to know how normal conduction works. Sinus node fires, you get your P wave, goes down the AV node, it activates the myocardium via the His-Purkinje system, and you have a nice sharp peak. Okay? And then depolarization occurs. And the wavefront is such. So this is why you have a sharp peak when you're going down the His-Purkinje system. Because it's fast. This is ventricular tachycardia. You got to focus here. Whether it be a reentrant circuit or whatnot, this is the focus. And it fires out over the myocardium, and you notice that it is sluggish and slow. So it is direct activation, so it's slow and unpredictable, whereas the His-Purkinje activation is fast and predictable. Similarly, if you look at left bundle is, the initial segment is always spiky and sharp because you're going down the normal conduction. If the left bundle branch block, you're going to conduct up the right bundle, and you get this pattern, and then it depolarizes subsequently through the myocardium, and hence you have a more slurred and slowing. So when do you use the basal algorithm? You have wide complex tachycardia, new patient, no history, maybe Brugada Verikai. Old patient, you have the history, basal algorithm probably at the onset. If that does not fit or answer your question, maybe go down the Brugada or Verikai algorithm. They can all be used in conjunction to try and get to the answer. How do you manage it? So if you have wide complex tachycardia and the patient is stable, you have a new patient, Brugada, old patient, you can do the same thing as just now. Unstable patient, treat as VT. Unsure, refer to your local EP consultant. So what are the key points? So the take-home message should be that if you're going to diagnose SVT or VT, you need to be very sure that you're making the right diagnosis because treatment makes a difference. If you give the wrong treatment for either or, you might end up with more problems than benefit. 70% up to 80% of wide complex tachycardias are VT. So if you see a wide complex tachycardia, it's VT until proven otherwise. If you do not know and you can't rule out VT, it has to be VT. So do not diagnose an ECG in isolation. So always correlate clinically. There's always going to be someone there who can give you some history. whether it be your house office, your medical officer, your physician, your cardiologist, your clinical fellow, there will be someone who can give you some information. When in doubt, diagnose a wide complex tachycardia as VT, and never forget to assess a patient clinically and follow ACLS guidelines. I think someone else will be talking about how you manage these things, but the crux of all this is basically to differentiate SVT and VT. So if I were to say basal criteria, I would use that. We've been using that since the paper was published. It's been helping us a lot. It cuts down the time. It's easy to use. Just look at lead 2, look at AVR. If it's a slurred more than 40 milliseconds, more than one small box, then it's most likely VT with a high index of probability. If there is clinical history to support it, it's even more probable. That doesn't fit. You can use the easy things such as AV dissociation. If the AVR is up because of depolarization, or the wavefront is going from the ventricles up into the atrium, so AVR is generally upright. That's the AVR algorithm. So these are things that you can use to make wide complex tachycardia, which is inherently a difficult